Good evening, everyone. For those who don't know me, I'm David Werring. I'm the head of Department of Brain Repair and Rehabilitation, which is where Professor Panicker is located. It's a great pleasure to see you all here, who are fighting the storms and the transport difficulties and everything else that life throws at us these days. But it's a great pleasure now to welcome you all, members of Jalesh's family, friends and colleagues. And it's a particular pleasure to introduce Jalesh, who's become a friend and an excellent colleague over many years. So you'll know the format, but I'll just remind you. So I make a very few remarks now. Jalesh does his inaugural lecture, which is the main event. Then we have a vote of thanks. I'm very pleased that Professor Kailash Bhatia is here to do that. And then, of course, we have a drinks reception, which will be just outside in the lobby. So Jalesh, he's recognised nationally and internationally, and he's an expert clinician scientist. And he's in a critical but under-recognised subspecialty of Uro-Neurology. And anyone who's clinical in the audience will understand the huge impact these symptoms have on the quality of life of our patients, and how really lucky we are to have such a comprehensive and expert service at Queen Square that Jalesh leads. I think we are so fortunate that no other centre has this kind of access to this specialist advice. Jalesh is another great example of the powerful and unique partnership between the Institute and the hospital. And he's achieved a very exacting standard to reach the distinction of Professor at UCL. And he's done this via the route of being an honorary clinical academic. In other words, he's employed by the hospital mainly, which means he juggles a very busy clinical workload with limited protected and funded academic time. And I think he's an exemplar of how really excellent clinical academics can thrive with this pathway. But he also illustrates some of the challenges faced by honorary clinical academics in their career progression. I think Jalesh might mention some of these in his lecture. But in my view, honorary clinical academics are often the unsung heroes of the clinical research world here at the ION. And another one's just walked in here, Valeria. So honorary clinical academics are, I think, underappreciated in many ways. So I won't go on for too long. I'm just going to briefly go through Jalesh's appointment. He's at the Department of Brain Repair and Rehabilitation since 2008. He was promoted to Associate Professor in 2017. And he's established a translational research program in neurogenic bladder and sexual dysfunction. And this is really one of the very few academic Uro-Neurology research programs in the world, let alone the UK. He's been chief investigator of over 15 studies, focusing on neurological pelvic dysfunction, treatments for neurogenic bladder dysfunction and phenotyping across neurodegeneration, neuroinflammatory and genetic disorders. He's published over 160 peer-reviewed articles in prestigious journals such as Lancet Neurology, Annals of Neurology. He's co-edited 2 textbooks. And he's got a very strong track record in teaching, including the master's programs and internationally across the Movement Disorder Society, the European Academy, European Committee for Treatment and Research in MS. And he's chief organiser of a biennial Queen Square Uro-Neurology teaching course. And it's actually quite exhausting just going through this, Jalesh. So I don't know how on earth you managed to do all this. You also nurture the next generation of researchers, supervising PhD students, and not only neurologists, but allied health professionals. So I'm very pleased to have known Jalesh personally for many years, including as head of department. He has not only shown these academic abilities, but true institutional citizenship as postgraduate tutor. And he's really stepped up to the mark, supporting students, giving so generously of his own time, despite so many other demands. And it's truly incredible what he's achieved, in spite of this very heavy clinical workload. So let's now turn to the main event. So Jalesh's inaugural lecture, and he's called it Chronicles of an Electrician in a Plumber's World, Leaps of Faith on a Rollercoaster Journey, which is one of the most intriguing titles I've heard in recent memory. And perhaps we better have a disclaimer, Jalesh, that it's unwise for members of the audience to combine electrical work with plumbing. But you're going to explain to us further what the title means. So without further delay, over to you, Jalesh.
Thank you very much, David, for those words of introduction. And it's an absolute delight to see a turnout, despite the rains and the train strikes and delays. And I would like to, at the outset, thank everyone in the audience, plus those who have joined online to come and listen to this inaugural lecture. I'll start with a disclosure slide. It should work. So the disclosure essentially is that this is my disclosure. And essentially, this is really a lecture on the journey of how a clinician can do some academic stuff on the NHS. But that journey actually begins on Cape Cod in Massachusetts. And so my dad comes from a very humble sort of a beginning in Kerala in India, worked his way up the ladder, and then on a full scholarship came to the United States to do a PhD in ocean engineering in Berkeley. Did his postdoc work at Woods Hole on Cape Cod, at which time I was born. He was out on the high seas at the time collecting data for his research project, and they aptly named me Jalesh, which means the master of water. Little did they realize that many decades later that their son would master the waters within the body. Life was great in those days. A year later, my sister Anuja joined us, and it took a while getting adjusted to having a sibling, as you can see, but we soon hit it off, and to today we are close friends. And so after this period in Massachusetts, my dad left academia and went into industry, an ocean engineer interested in R&D for offshore sort of extraction of oil, and where to go but Texas, with the Gulf of Mexico nearby and sitting on the Permian Basin. And so we migrated to Dallas, Texas, and many of you are familiar with what Dallas is known for. The Dallas-Fort Worth is famous for its rodeos. If you're an NFL buff, the Dallas Cowboys, and of course, a decade and a half before was where John F. Kennedy was assassinated. But what we really know about Dallas, of course, comes from the television series Dallas, which enthralled audiences across the world, even to today. And the intrigue about who shot JR is still a discussion point at some dinner conversations. We certainly didn't live on South Fork Ranch or anywhere near that. But we did have a happy childhood. Had our own sort of petting farms to go to. Did a bit of gardening, which my mum was interested in. And coming from a background of a first-generation immigrant family, hard work, perseverance were key, and were sort of values that were instilled at a very young age. Now, those of a certain age in this audience will agree with me when I say that the 1980s were probably the best time to be living through, culturally, music, cinema, and the personalities and everything that emerged from that decade has influenced many decades subsequent to that. And my very first academic achievement was actually graduating from kindergarten. And I still remember the diploma that was on our wall for many years. A very proud achievement then. But really the true achievement was when I became an Eagle Scout at the age of 13. So Boy Scouts was actually quite transformational, because at a young age, with a tender mind, imbibing those sort of Scout rules and laws and the Scout oath actually had something to do with the subconscious, but also made a very strong moral compass that still stands with me. The motto, "Be prepared," is something that I still hold within me when I see any patient, go to any difficult meeting, and has done me good. In Scouts, one has opportunities to develop leadership skills, and that's all tested when you go through your journey to become an Eagle Scout, which in the UK the equivalent is a King Scout or a Queen Scout. And also you acquire different merit badges on the way, which in the process, therefore, I learned how to weave baskets, learned about geology, life-saving, and life sciences as well. I would say that we had integrated well with American society, and my parents were quite particular we did so. But my parents were also quite keen that we retained our links with the motherland, and so we would make it a point to celebrate whatever festivals are there. So Onam is the important festival of Kerala, and this is me at the edge with my sister enjoying the typical Kerala feast on plantain leaves. We would also make it a point to visit India very often. There's an opportunity to learn Carnatic music, engage in activities that I certainly could never engage in the States, and be close with relatives. These are my paternal grandparents. My maternal grandparents is my paternal grandmother, and so having close links. Now, my dad is not one for the merry-go-round, but clearly one for the roller coaster. And when he arrived in the US, it was very clear that he never wanted to stay there forever. And so, 20 years on, we took a one-way ticket back to India, and essentially we just started from scratch. We landed in Trivandrum, which is the administrative and arguably the cultural capital of Kerala. Now, many of you might have heard of this state. It's the southeast sort of portion of the peninsula of India, which is visually quite scenic, with the sandy beaches, the tea estates, and beautiful backwaters. I would encourage you to visit Kerala, not just for the beauty, but also to appreciate the art forms. And some of the intricate art forms have evolved over many hundreds of years, such as Kathakali and Mohiniyattam, and also the Kerala martial arts of Kalaripayattu. Kerala is quite unique, and it's known in the trading world for centuries. First it was the Arab traders, and then it was the European colonizers, but essentially it was after black pepper, what was called black gold, and also other spices such as cinnamon and cardamom, which grew in the hills of Kerala. And because of this exchange, there was an exchange of ideas and people over centuries. And in fact, Kerala is a place where Christianity first came to India through St. Thomas. And also through the Arab traders, the first mosque in Kerala was established. So when Vasco da Gama came to the Malabar coast, he was actually to trade and also to bring Christianity. He was surprised that Christianity had already been established in Kerala and other parts of India nearly 1,000 years prior. And so with that exchange of ideas also, Kerala is very unique from the rest of India. Manu S. Pilla has written a fascinating novel about the Chronicles of the Royalty of Travancore, which is the southern part of Kerala before independence, and describes at length about the reasons why Kerala society has actually been a role model for many other societies in India and abroad. And one was the matrilineal system of inheritance, which and also a royal family, particularly the Travancore family, that had invested heavily in education and health in the beginning of the 20th century and in the 19th century. Because of the exchange of ideas in Kerala, there was quite a bit of widespread of political thoughts. And in fact, within 10 years of independence, Kerala is the first place in the world where there was a democratically elected communist government. And quite a bit of quite a bit of social reforms were made, which is not dissimilar to the social reforms in post-war Britain. Because of this, Kerala has been a role model and leads on different sort of metrics in terms of life expectancy, maternal mortality, gender development. However, in the last few decades, there's been a flux, and there's been quite a bit of changes socially and religiously and culturally. And it's actually a tale of two cities in a way, that there's so many areas to emulate. But Kerala society today is plagued by various challenges, a very high emigration rate, and one of the lowest rates of population growth, to such extent in certain parts of Kerala, the demographic pyramid is inverted, and there are no young people left and just the elderly who are left behind. It's also the state with one of the highest suicide rates in India, and the highest per capita alcohol consumption rate and the highest divorce rate. And these are the things one would appreciate hopefully when visiting Kerala, not just for the scenes, but also how Kerala culture and society has evolved over the decades. Entered medical school in '91, and Trivandrum Medical College is considered as a pinnacle in terms of medical schools in Kerala. It was opened by, the opening was inaugurated by the first Prime Minister of India, Jawaharlal Nehru, and this is where I had completed my MBBS and completed my MD in internal medicine. I then moved on to Bangalore for neurology training to the National Institute for Mental Health and Neurosciences. This certainly is not a place for the fair-hearted. The residency training in NIMHANS is quite rigorous and quite tough. A working time directive is a distant dream at NIMHANS, and a typical on-call would be the first 24 hours would be looking after patients at A&E, going to the wards, clocking the patients with your junior resident, doing the EMGs and nerve conduction studies, getting some sleep, and then it's a grueling ward round that could last for several hours. And this went on for 3 years, amongst which we had journal clubs and seminars. At this point in time, it was general neurology, but NIMHANS was slightly different from the other neurology centers in that there is a very strong neurorehabilitation link, plus a very strong links with neuropsychiatry and the basic neurosciences. But amongst that, there was also some interest in neurogenic bladder. And two people stand out. One is Shiva Nair, who's now Professor Shiva Nair of Neurodisabilities in Sheffield, and Professor Arun Tali, who introduced the first ideas about neurogenic bladder management, which amongst the busy residency was impossible to sort of imbibe fully, but still planted some ideas that would help later on in life. And despite that, we were expected to produce research, and my thesis was on acute disseminated encephalomyelitis. At that time in India, there was very little known about the functional outcome predictors following this condition in the Indian population. And in the same piece of work, it was my first opportunity to actually collaborate with another department, and this was the neuroradiology department, which is well advanced at NIMHANS, where we described sort of MRI characteristics in ADEM in that piece of work. It was also an opportunity to actually start understanding bladder dysfunction, and with Shiva Nair, we actually evaluated the bladder dysfunction in these patients with ADEM. So that was NIMHANS, and then after the 3 years, I felt it was time to, well, before I left Bangalore, of course, the most important event happened, so I got married. And so this is Parvati Panicker, who's actually a software engineer, and ours was a typical arranged marriage. I met Parvati for maybe an hour with both sets of parents in the other room. 4 hours later, I told my parents this is the one, and 3 months of a courtship, which involved an engagement which I couldn't attend because of an on-call that came up. I made it for my wedding, and we got married. And the typical sort of marriage in the Nair community is a very short, brief one, and this is following social reforms in the 20th century. And our marriage function, which is all of 7 minutes. And believe me, this is actually a simple marriage. So we then decided to leave Bangalore and come back to Kerala, but this time to the financial capital of Kerala, which is Cochin. Now, Cochin is a sprawling metropolis and has an international port, and so much of the trading actually for centuries was going through Cochin. And I joined the Amrita Institute of Medical Sciences in Kochi. Now, this is a very unique institution because it's a private sector institution which actually prioritizes academic work. Led spiritually by Mada Amridandamai, who we otherwise fondly call as Amma. And this was a period where it was an opportunity to actually sort of consolidate my neurology understanding and worked with an excellent team. It was also the time when both my children, there's Nivedita in the audience and Advait, who's joined in the back, were born. And I was lucky to actually join a team led by Professor Anand Kumar, who is a doyen in the field of neurology in India, but a gentleman. And when I joined the department, said that, look, all my junior doctors, they'd go to either MS or Parkinson's, or there's 3 or 4 sort of well-known specialties. I want you to go somewhere different. And coming from NIMHANS, when neurorehabilitation had such strong roots, it was but natural to consider developing neurorehabilitation. In the subsequent 3 years, we set up a comprehensive neurorehabilitation unit, and it became evident that bladder, bowel, sexual dysfunction was something that just was untouched. So during that course, we began to phenotype the bladder, bowel, sexual dysfunction neurological patients. And during this period, a patient with urinary retention came. And we reached a stage where we couldn't really understand how to work up the patient or even to treat the patient. And I wrote to Shiva Nair and asked, well, what do I do? And Shiva Nair wasn't sure, but he said, I do know someone who might know, and that's Claire Fowler, who's kindly joined us this afternoon. And why don't you email her? And of course, Claire Fowler was a name that was vaguely in the back of the mind from reading Bradley's textbook of neurology just before an exam for to complete my training. But I did send the email, not expecting a reply. But within a couple of days, I had a reply, and there was certainly an interest in urinary retention. It was clear that Claire had actually mistaken me for someone else she had met, and I tried to correct that. But despite that, there was something in it which I still don't understand, that Claire felt that, well, this is someone interesting, and at some point she then said, well, why don't you sort of come and visit in London, we can understand urinary retention together. Now, this was a major decision point because we were quite settled in Cochin, and my wife was in one of the best IT firms developing software. I was made an associate professor that year and a unit lead, and we had a strong residency program. The children were all well settled or getting settled. But we then decided that we're not one for the merry-go-round, but we should sort of jump onto the roller coaster. And so leaving everything behind, including parents from both sides who were obviously slightly disappointed with our decision, and with just a few £100s in the bank, we landed up in dark, rainy, grey Britain in the middle of December. And so the transition was rather abrupt. We ended up at the doorstep of my cousin, KB Das, who's here. He's a pediatric epileptologist at Great Ormond Street Hospital, who kindly took us in for a few days. And it took several months, if not years, to really try to understand what we were doing there, but also to try to get roots into a country. I naively thought that, well, living in the US, it's going to be like in the UK, but realized that that's certainly not the case. And Claire, of course, had nurtured a department that was small but very loving, and Colette Haslam and Gwen Gonzalez were kindly, and Shahid Khan, who's here, who's the clinical fellow who was with Claire at the time, kindly took sympathy and understanding my plight, sort of took us through it. Claire, of course, had foreseen this, and I would say it's probably and realized that we were looking for accommodation, actually suggested that, well, there's some accommodation I can organize very close to where my children live. And of course, we didn't think much of it at the time, but that was sort of a masterstroke of genius, because that was actually a close link, an informal link with how British life is. And I think without that sort of a connection, I think we probably would have headed back after a year. But we did stay on, and slowly we began to understand ourselves. So from a plumbing perspective, if you think of lower urinary tract dysfunction, either it could be urinary incontinence, and then if you think of the plumber, you just fix the leak, or it could be urinary retention, which you just need to unblock the drain. And of course, that's not how urology is run, but when you think about the field of functional urology and neurourology, for decades prior, there was basic scientists, neurologists, physicists, and surgeons who actually realized that it wasn't just a plumbing problem with the bladder, but also there's the electrics that have to go hand in hand. And though the electrics and the plumbing have to be kept separate, it became clear that they have to be understood together. And so I entered a field where actually there was quite a bit of interest amongst the electricians and the plumbers to actually solve the problems of the lower urinary tract. Now, Claire's work was in chronic urinary retention in women, and her major contribution was in understanding idiopathic urinary retention in women in an era when people thought it was all psychological, and terms such as hysterical urinary retention and psychogenic retention were sort of synonymous with this condition. And in that period, Claire and her colleagues at the time actually identified a group of women in whom there was a clear biological signal in the electromyography recordings of the urethral sphincter. Now, I will play these EMGs just to make the audience aware about what it was. And so this is the EMG recording from the urethral sphincter normally. So those of you who are familiar with the urethral with EMGs will recognize that even at rest there is tonic activity, and also that the motor unit potentials are smaller. Now, in this group, what we're seeing were complex repetitive discharges, often with very prominent decelerating bursts. which is certainly not physiological. And you can make up there are CRDs with different pitches, and so this sort of a signal was quite unique at the time, it was thought, and so it became clear that actually there is a biological basis for chronic idiopathic urinary retention, at least in a cohort of patients. So one of the first works that I was involved with was actually to look at the patient cohort of patients coming in, and when we prospectively evaluated women with retention coming into the department, what we realized is only 40% of the women actually have this condition, and the remaining 60% actually the cause remains unknown. What we also recognized in this study was actually that opiate exposure was a significant contributor in some of the patients, and the paper goes on to discuss the relationship between opiate use, urinary retention, and Fowler syndrome. Now, this condition is important to recognize because amongst sort of chronic idiopathic urinary retention, it's a condition that's actually eminently treatable with sacral neuromodulation. So nerve stimulation of the sacral S3 nerve root, something similar somewhat to deep brain stimulation, is highly efficacious, with which is a success rate of nearly 70%. However, this is a two-stage surgical procedure, and many of our patients have numerous comorbidities which make them not suitable for this. And so the question was, is there any less invasive option? So botulinum toxin, of course, is something that's known to neurology practice and clinicians across different specialities, and is essentially the principle is that if there's an overactive striated muscle, if it's injected with botulinum toxin, this relaxes that muscle. And essentially that was the principle. Of course, there was more science to it than I've just described. But the principle, based on this principle, we thought we're injecting the external urethral sphincter with botulinum toxin should help relieve the urinary retention, particularly when the problem is at the level of the urethral sphincter. And so in this first study, which was an observational study of women with urinary retention injected with 100 units of botulinum toxin, there were improvements in retention, the urinary flow, and voiding scores. Now, around this time, there were studies from other centers, particularly from Taiwan, that had shown similar results, but the randomized control trial was actually showed that there was no benefit. And we went through the data and realized that actually that it was a heterogeneous group of patients that are being studied here. Because once again, when you think about chronic idiopathic urinary retention, it could be a product of the blockage of the drain, or it could be a pump failure. And in many of these studies, it was a mix of patients that were being assessed. So we first tried to set up an RCT and soon realized that we would have no funders for this. Plus, because of the nature of the comorbidities of this cohort, it was impossible to get a clean group, which is required for an RCT. And hence we settled for a long-term observational study. And so we prospectively evaluated our women over an 11-year period. And Sarah Wright, who's in the room, was involved in analyzing this data. And what we found is that there was a high response rate to botulinum toxin, which is not dissimilar to sacral neuromodulation, with mild and transient side effects. What we found, interestingly, what we had expected to find was that where there was a high urethral pressure, that sort of predicted a positive response, which is one would expect with botulinum toxin. And what we also demonstrated was that with repeat injections, which being a striated muscle would be once every sort of 3 months roughly, it was proven to be a safe and effective treatment. So NICE then recently appraised this treatment, and with the data from Queen Square, plus data from our urology colleagues at Westmoreland Street, plus the data abroad, actually produced a guidance just this year, which actually supports the use of botulinum toxin for chronic idiopathic urinary retention, particularly in the cohort who have a problem with the urethral sphincter. And much of this was based on the research that was done at Queen Square. Now, that's not the end of the story of urinary retention, because the psychological comorbidities is something that had never really been addressed. But it became to a stage that we realized that this needed to be addressed from a clinical perspective, but also from an academic perspective. What is the possible relationship between the comorbidities and the voiding dysfunction? So we had set up a collaboration with John Stone at the University of Edinburgh, and Ingrid Howitzer was a clinical fellow who then came down to Queen's Square for a month and sort of reviewed our patients who had Fowler syndrome. And what she found was, rather not surprisingly, a very high percentage of women with functional neurological symptoms and different mental health issues. Now this, of course, was just a retrospective chart review, and it was clear that we needed to have some support with this. And then I went to Caroline Selai, who we all know in this audience knows is from the education unit, but perhaps is less well known, is a psychologist by training, and explained the problem and was able to convince Caroline to have a look at this group. And thus became a strong collaboration between Caroline and ourselves, who subsequently has actually joined the department, but also with neuropsychiatry. And in this prospective study, we found that actually the prevalences of comorbidities was far greater than we had anticipated. And being a psychologist and objectively assessing the comorbidities, nearly 80% of women were having comorbidities such as depression and anxiety, a high percentage with post-traumatic stress disorder, more than 50% were having some sort of functional neurological symptom disorder. What was slightly worrying, however, was that there was a high percentage of patients where there was self-harm and also a high percentage of childhood trauma, which includes physical and sexual abuse and adult trauma, none of which had been on the radar at Queen's Square and also in neurology centres across. And so what we realized that this is actually something that had to be addressed. We would try to uncover to unpick the relationship. And so the subsequent few years, we started to engage with different urologists on the platform of the International Consultation on Incontinence Research Society, where we opened up the discussion on psychological comorbidities in urology and bringing two sort of rather disparate fields together. And this led to a series of publications where sort of care pathways involving psychology assessment were discussed and included, but also guidance to urologists on the simple sort of assessments that can be incorporated in urology care. Now, till date, we still haven't been able to uncover that relationship. What I think is happening is that there's a cohort of women and possibly men, who we don't know, where there are numerous sort of comorbidities that are existing, and there's perhaps a psychological trauma or an antecedent event. And in a cohort of women, we know that in health there can be the abnormal EMG signals as well. And so then a trigger such as a trauma or an antecedent event then triggers off the urinary retention. But this is just speculation, something that we've not been able to establish. What we also started to do is to look into the relationship between sexual abuse and lower urinary tract symptoms, which is once again something that is sort of the elephant in the room in many urology consultations, but something that sadly it's something that could never really been adequately addressed, which came across in this systematic review that was one, very difficult to get published and finally went to an international urogynecology journal, but also demonstrated the extent of trauma and how but despite that, how it's probably underestimated. And this led to a plenary session at this year's British Association of Urological Surgeons, where there was a session dedicated to unexplained symptoms in urology, where the cystoscope cannot reach, where essentially these sort of functional symptoms, FNDs, trauma were all discussed, and this has led to now to our next review, where we're sort of proposing a pathway for urologists on how to assess and really to understand whether a history of trauma is significant or not, which is a work in progress. Now, not all urinary retention, of course, is due to a urological lesion, and so we performed a review a few years back looking at the neurological conditions that can present with urinary retention. And I'll give you one example. This is of a 40-year-old male who presented quite early on to urologists with urinary storage symptoms, but quickly went into urinary retention, had problems with sexual performance, bowel dysfunction, and there were absolutely no urological or neurological clues to the diagnosis. changes. When the patient came to us, underwent a urodynamic study, and when given the command to void, there was absolutely no detrusor pressure rise, suggesting that there's a detrusor failure. And when the patient underwent an EMG of the anal sphincter muscle, what we found was it was significantly abnormal. And this is the longest motor unit potential that was there, which was around 38 milliseconds, in contrast to the normal 10 milliseconds. So as a clinician, it was very clear that there was some pathology that was neurological, and it is likely that this would have been in the level of the sacral spinal cord. The urodynamics showing an atonic detrusor suggests that the intermediate lateral horn cell is affected, the bladder motor neurons are affected, and an abnormal EMG suggests that parts of the anterior horn, called specifically a hybrid group of neurons called the ONIF nucleus, was involved. But at this point, there was nothing structural to see and no neurological symptoms and sign further. The patient was coming in regularly, and we followed up the patient because we didn't have a clear diagnosis. And in the subsequent few years, started to develop neurological signs of ataxia and extrapyramidal syndrome, became bedbound, and within 11 years of the onset of the symptoms, sadly passed away. The family kindly consented for an autopsy, and it was clear this patient had pathology consistent with multiple system atrophy. And so what clearly was happening was that the patients were having urinary retention, which was considered perhaps more likely to be related to a brainstem pathology, considering MSA. However, there was absolutely no other brainstem signs for a number of years. And so in a cohort of patients, and subsequently, we've actually now picked up 7 such patients. The pathology is starting in the lower cord, and for reasons that are unclear, it gradually then sort of ascends to involve the rest of the brainstem, and then present with to a neurologist with the typical signs and symptoms of MSA. So that really got us thinking then, because we do know that the sacral spinal cord is particularly vulnerable to this condition of multiple system atrophy, and there are pathological studies from an autopsy and from animal models of MSA that clearly show that the areas involved, and particularly in the animal studies, quite early on, there's a dropout of neurons in the ONIF nucleus. So the question then became, well, if it can be shown post-mortem, is there any way that it can be shown in vivo? And it was around this time that Marios Yannakis, who's in the room, and Claudia Wheeler-Kingshott was developing a protocol, a high-resolution MRI sequences for the lumbosacral cord. And we then met, and Ahmed Tusi joined the group, and then subsequently Martin Elekti, who was a postdoc fellow at the University Hospital in Balgris in Zurich, University of Zurich, joined. And so our project then began to involve, to see the feasibility of this in patients. And also, particularly without MSA, would be the model disease to study. So the work that Marios had done was actually was through the high resolution imaging, was to actually demonstrate clearly the white and the grey matter in the lower spinal cord, and then segment the grey matter, and so therefore one would get an assessment of the area and the volume of the grey matter, and knowing what happens in MSA, what we hypothesized is there would be a volume loss in the grey matter. Now, it's that one of the many challenges is, of course, having a sort of a landmark to understand where you are on the cord, and they used the lumbosacral enlargement, which is sort of higher up from what we were expecting the pathology of MSA. So one of the first sort of projects within this, one of the first studies within this project was actually to see if it's feasible to actually image further down from the lumbosacral enlargement. And so the first work involved imaging throughout the conus medullaris, and it was demonstrated it was feasible to therefore segment the grey and the wide matter in further caudal to the lumbosacral enlargement. We then applied this in a cohort of patients with MSA and compared to that with an age and gender matched group of healthy subjects, demonstrated indeed that there was a significant volume loss in the grey matter in patients with MSA compared to healthy subjects, and that this volume loss in the grey matter, not only at the lumbosacral enlargement, but also the conus medullaris, correlated with their avoiding symptom scores that we were collecting with the patients. So for the first time, we could therefore say that there was an in vivo measurement of lumbosacral cord changes that could be used as a potential biomarker in MSA. So that was cord structure. But we also then got interested in cord function. And of course, sacral nerve functions is best studied using neurophysiology. And so the urethral sphincter EMG, the anal sphincter EMG will tell you about the motor somatic innervation. But of course, at this point, we hadn't really sort of had any sensory studies. When Martina came, we started performing the pudental sensory work potentials. And it was a patient who then pointed out to us that, look, I have sensory symptoms on one side of my perineum, but you're performing a test that's telling me about bilateral pudental nerve involvement. And so that comment actually then rung in our minds. And I took this comment to someone called Armin Kurt, who was working in Belgravs University Hospital and who has done some work with sacral neurophysiology. And so he suggested the idea of developing dermatomal sensory work potentials, where you could study the work potentials from the S1, the S2, the S3, and the S4 separately. And so we could then develop a platform to evaluate not just the sacral spinal cord, but also your sacral spinal roots at the sacral plexus and also the pudental nerve. The opportunities therefore became immense because you would have specialties such as urology, gynecology, amongst others, and andrology, and neurology and neurosurgery, who would be interested to understand if their urological symptoms are of a neurological nature, or if you have an unexplained sort of an MRI finding in the lower spine, whether it is actually causing nerve dysfunction or not. And so for this, we went to our clinical neurophysiology team, and subsequent to our initial discussions, Prasad Maladi, who was a neurophysiology technician then, had actually been independent of this, starting to develop dermatomoceps, and subsequently has joined our team. And with Sarah Simeone, who I think has joined, we then started to design a platform for pelvic neurological assessments, which includes the neurology and the neurophysiology. Now, pelvic neurophysiology tests were around for many years, but hadn't really had left the main sort of academic centers. And part of this was just practical reasons, is that neurophysiology, neurology, and urology were usually located at different ends of a hospital, and there was very little opportunity to have discussions about clinical and academic research questions. And also the fact that there was no way to actually evaluate the sacral root separately. So with this, over the subsequent 5 years, we developed this platform evaluating the somatic, sensory, and the motor innervation. And so we reestablished and we validated the pudental sensory work potentials in men and in women. Also, part of Prasad's work was actually to develop this dermatomal sensory work potentials for those individual sacral roots, and we had reliable responses. Also to set up the dorsal penile nerve conductions, and also incorporating the EMGs that we were already performing, and also integrate the bulbocavernosus reflex, which assesses the sensory and the motor somatic innervation, and also to assess the perineal sympathetic skin response. So we now had a platform that was set up that we could then now, which was validated and could be rolled out for clinical applications. And I'll just name two applications. And one was to understand this condition of MOG antibody disease. So MOG is myelin oligodendroglycoprotein, and antibodies against this can cause a disease, a neuroinflammatory condition, which can often mimic multiple sclerosis. Now, what's peculiar about this condition is that the conus is particularly vulnerable in this disorder, and patients can sometimes present, particularly with transverse myelitis, present in a urology department with urinary retention for a few days and then start developing their neurological signs. Also, when they recover, often they recover neurologically, but what often stands out is quite significant urogenital and bowel dysfunction. So Vivian Lee, who was a clinical fellow who was shared between the Queen Square MS Center and Uro-Neurology, was on the scene. And we then collaborated with Jackie Pallas, who runs a dedicated service for MOG antibody disease in Oxford. And we started to phenotype this group of patients. And we demonstrated the supraconal pattern of bladder dysfunction in this group, but demonstrated that despite this, there was quite significant conus injury that was remaining in this group, and that couldn't be identified in imaging of the conus, and so suggesting that the conus injury was profound but also persisting. The other group was that we were looking at was interested was the group with perineural cysts or Tarlov cysts, and Adrian Casey, who's pictured here, is internationally renowned in this field of sacral Tarlov cysts, and essentially there's sort of accumulation of CSF in the perineum along the sacral, particularly along the sacral nerve roots. These are often reported as being incidental and perhaps not clinically relevant. However, the reason for that, of course, it affects predominantly the sacral roots. And so if the patient doesn't report genital numbness or doesn't report persistent genital arousal or doesn't report bladder or bowel problems, then it is, of course, then an incidental finding. Sachet Shaw from Neuroradiology had an interest in sort of in pudental neurography and the sacral root imaging. And when Claire Henson joined me from the University of Sorbonne in Paris, just at the start of the pandemic, we had a project for her to phenotype these groups of patients who come with Tarlov cyst. Now, Claire came just when the pandemic was beginning, and of course the fellowship had been planned, and however the pandemic wasn't. And so she landed in London, and for half of her that 1 year she was actually sat in her studio flat at King's Cross, logging in through Teams every day and trying to extract whatever you were in neurology training, but also to do her research. But whenever the lockdowns were lifted and it was safe for her to come in and she was allowed to come in, she came in and completed her work. But what we found in that project was more than half of the patients who had Tarlov cysts, actually there was evidence of sacral root injury, which I don't know if there are any surgeons in the room, but I think it was quite, from speaking to Adrian, was quite important for them to decide on surgery, because an MRI doesn't necessarily say that there is root injury. What we also found in the study, that there was a negative correlation between nerve root injury and urinary incontinence. The mean age of patients coming in for this group is around 50 to 55, where there could be other causes for urinary incontinence. Until then, it was assumed that their incontinence, which could be stress incontinence or overactive bladder, was due to the Tarlov cyst, which was something that we were able to disprove in this study. Now, this project was actually quite successful, and Claire presented her work at our International Neuro-Urology Society meeting this year, and was actually awarded the top prize for this piece of work. And this was competing against different other sort of projects in basic science and clinical urology in relation to neurourology. Moving on to other areas, because of the excellent sort of a milieu at Queen Square, I've had the opportunity to work with so many different other teams to phenotype urinary sexual bowel symptoms and neurological disorders. Working with Rob Picatholi and his team, we were able to sort of demonstrate the extent of urogenital symptoms in mitochondrial disease. Working with Paula Ginty, who's in the audience, we were able to phenotype the bladder dysfunction in spinocerebellar ataxias and Friedreich's ataxia, and I'm pleased to say that the findings of our research has actually influenced the recommendations and guidelines for the symptomatic management of Friedreich's ataxia. Working with Robin Lackman and Lane Murphy, we were able to phenotype bladder and sexual dysfunction in men and women presenting with adrenomyeloneuropathy. Now, this is an X-linked condition, but what we found in the study was that actually women who were carriers of the gene were having as significant bladder problems compared to the men, and the bladder dysfunction was actually similar to what women, age-matched women with other neurological conditions such as multiple sclerosis were having. And also, we started to phenotype bladder dysfunction and functional neurological disorders. With the movement disorders team, Kailash Bhatia and Amit Batla, who's in the room, we were interested in evaluating nocturia in Parkinson's disease. And a review that we published a few years ago, we reviewed the different causes for nocturia and found that it's actually quite complex and it's heterogeneous. This is a typical bladder diary of a patient with Parkinson's disease with nocturia. The figures in the green rectangles is actually the daytime voids, and what's in red is the nighttime voids. And for someone who does the maths, it's quite significant. They're getting up 4 times a night, and they're producing nearly 50% of their urine output in the night, which is what we call nocturnal polyuria. And so one piece of work that we were engaging with was to look at what the other causes for nocturia was. And we hypothesized that there could be a disorder of the circadian rhythm. And so a study that was funded by Parkinson's UK evaluated exogenously administered melatonin for nocturia and Parkinson's disease. And what we demonstrated was a significant improvement in nighttime frequency and bother, and also improvements in the average urine volume produced in the night. Another successful collaboration was with Valerio Udici in the room. Now, we all know about the autonomic nervous system, and it's seen as in this depiction as a unified concept. But actually, in clinical practice, in centers across the world, the assessment and management is actually dichotomized, and you have cardiovascular and pseudomultitude dysautonomia and urogenital and bowel dysautonomia, and often the management isn't coupled. So Valeria and I set out to actually think of a pathway whereby we actually merge and look at autonomic dysfunction in a more holistic manner. So we set up a fellowship between the two departments, and Ekwat Vijayananda is actually the fellow who joined. And our first piece of work was the phenotype bladder problems in one of the common, or one of the neurodegenerative autonomic disorders, pure autonomic failure. What we found was more than 80% of patients with this condition had nocturnal polyuria. But rather surprisingly, and for reasons that we don't fully understand, was that we found no correlation between the nocturnal polyuria and their other cardiovascular parameters such as postural hypotension and supine hypertension. But what's actually probably will be more impactful in terms of output from this fellowship is a review where we've actually gone back and looked at lower urinary tract dysfunction across all the autonomic disorders, which has actually never been done before. And this is something that will be completed next year, which we think will be received well by the autonomics community. So inaugural lecture is never complete without something about the future. And for someone who's a full-time clinician, my future is actually very much intertwined with the future of the NHS and its uncertainties. And it's very difficult to say actually what would be the future in terms of research. However, irrespective of being on the NHS research, I very much would go by what Yuval Harari writes in Homo Deus about the future, and how emotional flexibility is the key, because we all will reinvent ourselves when we have to reinvent ourselves. And so what I say in the next few slides might be entirely different what happens in the next 10 years. But essentially, what I'm quite interested in is identifying brain disease early on. And the EAN has just launched, the European Academy of Neurology has just launched a strategy of brain health to sort of promote positive brain health. But also, which part of this project is to identify the very earliest signs of brain disease and how we can mitigate, address at that point. And so come back to multiple system atrophy, where urinary and sexual dysfunction, as was depicted in that case illustration, occur quite early in the course of the disease. And if one were to identify this as being specific for MSA, then therefore these patients might be potentially suitable for a disease-modifying treatment. So what I would like to do, if the research time was available, is actually then to marry the high-resolution MR imaging, the sacral cord, and the pelvic neurophysiology work in patients who haven't developed MSA, but whom we suspect may develop, and seeing if these can be accurate imaging biomarkers, because clearly the sacral cord pathology is occurring quite early on in this group of patients. The other area of work that I think that I'd really like to see is in developing Uro-Neurology training. And those of you who are clinicians in the room will agree with me that actually the understanding of the neurogenic bladder bowel sexual dysfunction is near zero when you complete neurology training, as was in my case as well. In a survey that we recently carried out with the European Academy of Neurology to understanding about autonomic symptoms, what we found was more than 50% of respondents had low or no confidence in managing urinary, bowel, or sexual symptoms. And in the survey, what we also found, however, was that those who took part rated it that it was very important for a good neurological clinical practice. So over the years, we've been, as David alluded to, we've been sort of running sort of courses which are didactic lectures and also some sort of case discussions, which have become sort of probably the only neuro-urology course in the UK. And then we've also at the level of the European Academy of Neurology, year on year been successful with running workshops on sexual dysfunction, urogenital and bowel management, and also we've been able to successfully marry urogenital dysfunction with cardiovascular dysfunction. Now, over the pandemic, it became clear that we couldn't carry on with these courses face to face, and it was an opportunity to have a rethink and think about scaling up. How can we make this much more spread? And also post-pandemic, it became very clear that as clinicians, we just wouldn't have the time to organize these meetings. And so then we came to the Neurology Academy, which has a 20-year track record of developing different academies, which are specialty specific, and set up, and we have now just a few months ago, I've set up a Uro-Neurology Academy, which successfully ran a webinar in July, and we're having our first masterclass later the year. Now, this is a platform where individuals who are interested in neurogenic bladder bowel management can come for training, but also has a service component. And so people who then go back to their respective centers, it provides support to understand how to develop a service with the challenges of the NHS. Also, it has what we eventually will see that this will evolve into a research platform as well. Another sort of change in strategy was actually to move from didactic lectures to hands-on courses. And this year at the EAN, we've been successful with a hands-on course on Uro-Neurology, where neurology trainees and consultants will actually be going through different stations, learning how to use a bladder scanner, learning about lubricants and vibrators for sexual dysfunction, and also sort of having sort of one-to-one discussions about sort of what history to ask and how to interpret symptoms. And we think having a much more hands-on approach will actually lead to a generation of neurologists who have inbuilt in them an interest and also carry on with sort of practicing neurology in their respective fields. The other piece of work is actually with regard to developing managing guidelines, because the guidelines for the management of neurogenic bladder are very much urological oriented. A practicing neurologist will sift through this and realize that after page 2, there's very little that they can offer their patients, and hence inevitably have to refer to an academic center. So to bring this down to the neurologists, through 3 societies, the EAN, the European Federation of Autonomic Societies, and the International Neuro-Urology Society, we have now set up a project to develop guidelines. And this is a multinational task force across 4 continents, and with 2 lovely colleagues, Alessandro Fanciulli from Innsbruck and with Mario Habik in Croatia, where we're in the process of developing guidelines for neurologists, and which we hope will be available perhaps in the next year. And the next project will be looking at challenges of implementing this at a district general hospital level, but also at a tertiary care center, where the challenges are unique. So back to my disclosure slide. So yes, I am a full-time clinician on the NHS, but I think the way I've been able to navigate through that is really to have some very clear objectives, but also having excellent collaborators, which in Queen Square is replete with, and a wonderful clinical team. And so when I start with my thank yous, I must start with our clinical team. And I'm so pleased to see everyone here in the audience from our team. I think Claire developed a service from scratch, but I think the philosophy of kindness and compassion has been there. The clinicians in the room will understand that it's very difficult to do research if your clinical team isn't strong, and it works vice versa. And I think I'm ever so indebted to the clinical team because with a full-time NHS department, all these are full-time clinicians actually, to then do research alongside this means it's not just the commitment from one person, but from every single member of the team. And in particular, the nursing team, and we have Colette Haslam and Gwen Gonzalez here, but also Shobha Nair and Erica Dyson, who isn't in the photo, but very much in the audience. And I think a special thanks to the clinical team. I must also thank our management team, and there isn't a single individual, but in general, though of course it's not a direct bearing on the research, having a good management team who helps with the clinical service allows one to actually then develop research ideas on the side without having to worry about the day-to-day. Now, a very big thank you to Claire Fowler, of course, without saying, it's rather unfortunate that Claire actually retired very soon after coming to Queen Square, and so our professional overlap was rather limited. But Claire has actually been a mentor, but also a guide, and also a person to go to when things weren't going right, and I'm ever so grateful for all the support over the years. But but after Claire left, I think David Werring was clearly the person who really then sort of supported me. Of course, coming from stroke, not necessarily and the expertise in the field, I think understanding how research runs at the ION, plus in the UK. David had absolutely no obligation to run appraisals for an honorary, but I think out of the goodness of your heart, and perhaps doesn't appear on any spreadsheet at UCL, I think kindly, we used to have an appraisal every year, and those appraisals were actually important milestones because it would become clear, what needed to be done if I wanted to move up the academic ladder, not in terms of promotion, but in terms of impact as well, and a very special thanks to David. And of course to Kailash Bhatia, who has been involved actually. We only met after coming to Queen Square, but we have, I think at every point of the journey when there was uncertainty about where to go, what to do, someone who I could go to, and many thanks to that. And of course to the funders. Now I will be honest, my track record for grants is probably nowhere near most people in this room, just because of the inability to have time set aside for writing grant applications. Despite that, we have been successful with a few grants. Judith Jollies has put up with a lot of things, me coming at the last minute with applications. A special thanks to that. I must thank the NIHR, the BRCPA scheme. I was only awarded one PA, which was sadly taken away last year. And so essentially it's really just out of interest that's really been kept this going. But these funders, the funding that's been played, albeit small sort of pots of money, have actually come at critical periods of time to allow us to do the research that we were able to do. I haven't forgotten my roots, and so I still have every 2 weeks I meet with the neurologist and the urologist back at Amrita Institute in Cochin, and we discussed neurogenic bladder and bowel management. We ran a successful meeting for urologists and gynecologists last November, and we're running a 2-day course next April dedicated to the assessment and management of neurogenic bladder and bowel sexual dysfunction in collaboration with the Neurology and the Urological Societies of India. And of course my family. So this is my dad, who's in his early 80s. After he returned from the US, he never went back to R&D in oil exploration or in ocean engineering, but has actually been quite involved with social reform and social movements, and giving much more back to the society that made him who he was, which is what he wanted from the very beginning. My mum, who's actually an entomologist by training, has always been an inspiration to me. This is my sister, who's now a professor of child psychology, and this is her husband, and this is their daughter, and of course our family. So it's been quite a difficult journey, I must say. I won't say difficult, I'll say a challenging journey, shall I say, with many ups and downs. Clearly, I would say a roller coaster. But I think when we look back at 2007 and decided to hop off that merry-go-round and go onto the roller coaster, I think it's a decision that we will never regret. Now, my daughter is at university, has come in from Southampton this afternoon, and Advaid's leaving for university next year, and they'll all be embarking upon their own roller coaster journeys. But we hope that those roller coaster journeys will be aligned. So that's my journey and my inaugural lecture. Thank you very much for listening. And once again, thank you very much for all the support from Queen Square, from the academic side and the clinical side over the years. Thank you.
That was absolutely wonderful, Jalesh, hearing about your journey. And thank you all for turning up to celebrate Jalesh's promotion to professorship. Jalesh, nowadays, whenever one gives a vote of thanks, one looks up ChatGPT. And I must say, I looked you up on that. But what came up was a wrestler. So apparently, there is a world famous wrestler who goes by the name of Panicker, and he's from Kerala as well. And he has recently beaten the world's strongest man, so you may be pleased to know that. I was wondering, what do I talk about you? I mean, you've done such amazing work, and so I actually went back to when Claire Fowler, who I'm very glad to see is here, told me about you. And she said, do you know that there is another Indian like you? And very much sort of similar in the path, because she knew about my path, having been close to David Marsden and being on the executive committee. And there is this bright young man, she told me, from India, and you might want to meet him. He's come here to do some clinical work with me. And we set up a meeting, Jalesh, I don't know whether you'll remember that, but I remember that very distinctly. I found you as a very polite, well-mannered, and very enthusiastic. And I followed your progress over the years, and you've done so amazingly well. Now, for people who don't know Kerala, we talk about Kerala in India as God's own country. And Jalesh came from God's own country to the Queen's country, now the King's country of England, and on this marvelous journey, and how wonderful this journey has been. And despite the ups and downs, you've done so remarkably well. And David, you got his number of publications wrong. It's 200, actually, not 160 or 140. That's the latest figure. 25 book chapters, 2 co-edited books. Absolutely remarkable. And I think the work which you've done, despite being a full clinician, as you mentioned, under the NHS, is really remarkable. Sort of puts to shame many of the all-time academics, perhaps, that you were able to achieve all this. And I really want to sort of mention a few things which you did with me in your scientific work. The melatonin trial, I think that was fantastic. And this observation that, and we knew this, that people with Parkinson, they wake up a lot at night, and when they wake up, they pass water. But what we didn't know is that they wake up to pass water, and then they can't go back to sleep, and they're passing most of their water at night. And this was a sort of a remarkable observation, and that sort of led you to do the melatonin trial, which was very successful. And this is a big achievement. And the number of things you've done with the various people around here, with Paula Giunti, Friedreich's attacks, whole thing which you sort of told us about is really, really remarkable. What you may not know about Jalesh is and probably he did allude to this a little bit, he's a family man, as you saw that. Jalesh wakes up very early in the morning, I believe. Is that right? He wakes up early in the morning, and he sleeps early too, and he does a lot of his emails. So you get a sort of reply to him, and you get an email at 4:30 in the morning, and you say, what is he doing up at that time? He also makes breakfast, I believe, quite often. That's right, for the family in the mornings. And he is a great violin player. He knows Indian classical, and he didn't mention that, and heavily into Carnatic music, which is sort of South Indian music, which is very difficult to master, and Jalesh is extremely good at that. One thing which you didn't mention, Jalesh, and I was waiting for it, was this question about why do some people shiver when they pee? Now, Jalesh has done a program on this, and I was really interested to know about this myself, having had this symptom a few times, and I'm sure there are other people in the room who do that too. And Jalesh did a blog with the Naked Scientist. What sort of blog is that? I don't know, some organization. But this was picked up by 2 radio stations. One, the BBC Cambridge radio, I couldn't find it, and one place in Australia, a small radio station in Australia. But otherwise it's lost, so we don't know why people shiver when they pee. So you've got to, maybe tell us about that sometime. I've seen Jalesh grow and mature. I have worked with him very closely in the MSA Trust, where he's a trustee, and his contributions to the MSA Trust have been absolutely amazing. We really find him very useful. Jalesh is really one of his kind. And you heard that Uro-Neurologists are very few. I mean, when was the last time you sat next to another Uro-Neurologist? The only person I know is Jalesh. And you're right that we need to train more people like this. These are people who look at the lower end rather than the upper end of the brain. So there are very few of them. And Jalesh, you've done marvelously well. I think I have every confidence that you will have some more and quite remarkable landmark achievements, both clinically and academically. And I think we all join you in thanking you for all your work, but also the achievements you've had over these years. So if you would join me to give Jalesh
So I think the closing remarks need to be very brief because it's just me between you and the drinks refreshments outside. But thank you, Jalesh, for such a wonderful journey, both geographically and culturally, and also all the different places Uro-Neurology can go within the neurological spectrum of diseases. So I think it's really, I find it absolutely fascinating, actually, in all of those respects. And I didn't realise quite how broad your collaborations were. I mean, I knew that you are a very collaborative person and you're very successful at collaborating. And the way you speak so passionately, it's very, very clear why you're such a good collaborator, because you love the field and you're intellectually very gifted at doing this research. But I didn't realise quite how much you've done. I feel even more exhausted now about all your achievements, now that I've seen you whistle through them. So I think that was absolutely wonderful and very much enjoyed it. And I very much hope you keep going with your clinical academic work because you clearly have a gift for it. You're making a huge contribution. A new generation of people hopefully are going to bring Uro-Neurology more into the mainstream because that's urgently needed. There's a huge burden of disease and distress that many of us simply don't know how to deal with. So probably you need to clone yourself over and over again, I think, is what's needed in the field. So again, wonderful to see all of you here. And I think now it just remains for us to go and see what UCL's finest have provided for the reception. So thank you very much, everyone. Thank you, Jalesh. Thank you, Kailash. Thank you, everyone, for coming.